So I want to thank the Global Exchange Committee for inviting me to speak. This is going to be a talk on basically a patient who presents with critical limb ischemia and a chronic total occlusion. My name is Amit Srivastava. I'm an interventional cardiologist with Bay Area Heart Center in St. Petersburg, Florida. These are my disclosures. So this is an 85-year-old gentleman who is a stable Rutherford Class 3 claudicant for the past 2 years, presents now from home with acute onset cyanotic pedal discoloration involving the left foot and rest pain for the past 2 days. Past medical history is significant for most people in this situation. Diabetic, hypertensive, hyperlipidemic, had a history of remote 4-vessel bypass surgery over 15 years ago, history of prostate cancer, and chronic kidney disease stage 3. Physical exam was significant for a cyanotic left foot with severe rest pain and blanching upon straight leg raise. Motor function and sensation were intact with significant pain with left calf muscle compression, significant for ischemic myopathy. Labs were significant for normal white blood cell count, mild anemia, platelets were normal, and a creatinine of 1.7. An arterial duplex ultrasound was performed in the emergency room, significant for a peak systolic velocity in the left common femoral artery of over 500 centimeters per second. He had a known mid-left superficial femoral artery occlusion with post-occlusion spectral dampening and broadening. And flow was only noted in the left posterior tibial artery at the time of the ultrasound, with retrograde left anterior tibial artery flow consistent with collateralization. I'd been managing his peripheral arterial disease for the past 2 years fairly conservatively just because of his comorbidities. And a surveillance ultrasound that had been done in the office just 6 months ago had demonstrated a peak systolic velocity in the left common femoral artery of less than 300 centimeters per second. So there was a definite change when compared to his prior imaging. He'd been managed fairly well medically: aspirin, clopidogrel, metoprolol, succinate, atorvastatin, and insulin. And upon arrival to the emergency room, patient was started on a heparin drip. I saw him in the ER and then scheduled for angiography later that afternoon. So I think at this point, before we move on to the angiographic images, I think it's really important to have a game plan when you take a patient with critical limb ischemia to the cath lab. Understanding that there's a big difference in the treatment goals between a claudicant and a patient presenting with critical limb ischemia. In this situation, the most important thing is get straight line blood flow to the end organ of interest, which is the left foot. And I think it's also important to have a basic understanding of the data regarding surgical revascularization for those patients presenting with critical limb ischemia versus the endovascular data. And also it's important to keep in mind, what are your surgical targets? What are your surgical bypass conduits, as well as surgical comorbidities that might make a surgical operation much higher risk. I think it's really important when you have a critical limb ischemia patient not just to take them to the lab and wing it, but have a good game plan going into the case. So at this point, we'll talk about the data regarding surgical intervention versus endovascular intervention for critical limb ischemia. When we look at bypass grafts in critically ischemic patients, whether you look at above the knee or below the knee, autologous vein bypass grafts do fairly well at 6 months, 12 months, and have a good long-term patency. However, once you start transitioning over to the use of PTFE bypass grafts, especially below the knee, which have much lower patency rates, you can see that the patency rate and durability at 6, 12 months, and longer is significantly lower. Previous data regarding the use of endovascular intervention really was comprehensive to the level of the P1 segment of the popliteal artery. There's very limited data regarding endovascular intervention for patients who get intervened on in the P2 and P3 segment of the popliteal artery. Dr. Shiner published this data regarding interventions with 12-month results into the P2 and P3 segments of the popliteal arteries, with a significant proportion that were actual chronic total occlusions. And what the data showed is that primary and secondary patency at 6 and 12 months were significantly better than that of the PTFE bypass graft intervention, and over 96% secondary patency rates at 12 months. So now, going back to our patient, I don't think surgical intervention was going to be a good option for him. We know that he had a distal femoral popliteal occlusion. We also know that he has multiple surgical comorbidities, and most importantly, has no autologous vein to use for bypass. So the modus operandi here is to go for a purely endovascular approach. And as we know that this is distal femoral popliteal disease that is severely calcified based on his ultrasound, the plan was to use Supera stents for the intervention. Now, with the initial angiogram, you can see why the patient was so critically ischemic in the sense that there's a very severely calcified, severely stenotic left common femoral artery lesion that's impairing blood flow to both the SFA as well as, more importantly, the profunda, which is probably why the patient became so profoundly ischemic. Now, in this situation, we were able to get a wire down to the distal popliteal artery and exchange it out for a supracore wire because there was significant aortoiliac tortuosity. The gentleman's 85 or 86 years old, had very significant aortoiliac tortuosity. I was able to get a 7 French sheath into the proximal superficial femoral artery. My approach to patients like this is I almost always, in the critical limb ischemia situation, go with a 7 French sheath because the bailout options are almost invariably 7 French. Whether you have an aortoiliac complication or perforation in the superficial femoral artery, I think you're better suited by making sure that you start off with a 7 French system. So I was able to get a wire down across the lesion, and we started to do angioplasty. And unfortunately, you can start to see that there was already fistulization that had been created. And with standard semi-compliant balloon angioplasty, all our balloons were noted to rupture because of the calcified nature of the SFA. So at this point, switched out to a Dorado non-compliant balloon. This is a 60200, and did several prolonged balloon angioplasties of the superficial femoral artery and popliteal artery. Now, the reason why outflow was, so we got a good angioplasty result, but still had no outflow in the superficial femoral artery and popliteal artery, and that was because of the P2, P3 segment popliteal artery total occlusion. So at this point, pulled the sheath back to the common femoral artery to basically allow all our sources for collateralization to light up what actually may be present below the knee. And as the ultrasound suggested, there was a posterior tibial artery as a single conduit to the foot that was open. So at this point, planned on getting pedal access, and essentially we're going to need to do a safari technique. And so what you can see here is got posterior tibial access under ultrasound. You can see there's still hang up of contrast in the P3 segment of the popliteal artery, and you can see that as there's a long total occlusion extending from the popliteal artery into the tibioperineal trunk, with a lot of calcification in the tibioperineal trunk. So at this point, chose to use an 018 glide wire gold with a support catheter. As we know, when you use a support catheter, it increases the gram weight tip of your wire 2 to 2.5 times. And I was able to navigate the total occlusion from the retrograde approach. But unfortunately, we had a wire in the subintimal space from above, and I had a wire in the subintimal space from below, which you can see here. So at this point, really necessitated the use of safari technique in order to basically externalize the wire. Safari stands for Subintimal Arterial Flossing Antegrade-Retrograde Intervention. So I think at this point, when you're planning on using safari technique, it's important to realize that the balloon that you use from the antegrade approach or the retrograde approach should be as close to 1-to-1 size for the vessel as possible. That way you push your dissection flap up and make the dissection flap as thin as possible to allow for crossing with the wire. So that's what we did here. Angioplasty with a 6020 balloon, and I was able to pull the wire back and then went easily from the retrograde approach into a transit catheter from above, externalized the wire. And so this is basically an anatomic or a schematic representation of what we're trying to do with safari technique. But really, I think that thing to highlight is what you're trying to do is push the dissection flap up to the wall of the artery as much as possible to facilitate easy navigation of your wire. So once the wire was externalized, continued the intervention from the antegrade approach. Did several prolonged balloon angioplasties, and as we planned on using Supera stents here for the intervention, as has been told earlier in this conference, very important to have adequate predilation. So initially started with 5 and then 6 millimeter balloons. And you can see that we start to get pretty good luminal improvement here. Still wasn't happy distally with our angiographic result. So used a 6 millimeter non-compliant balloon at high pressure. And then ultimately put in 3 Supera stents from the P3 segment all the way to the distal left superficial femoral artery. And final result was definitely acceptable. And I think that in this situation also, you're not done once you've got antegrade flow. As there was a single vessel to the foot, before we pulled the pedal sheath out, we had a wire down the posterior tibial artery, had a 3-millimeter balloon at the side of the arteriotomy. Once the sheath was pulled out, it did a 3-minute inflation at the arteriotomy to make sure that we had preserved PT flow to the foot. And this is just an injection through the pedal sheath. A lot of collateralization, but only one named vessel truly. I actually just, before I came here, had our 12-month follow-up with the patient. Walking with Rutherford class 2 claudication, amputation was avoided, and as with most of our patients in Florida, he's still golfing regularly. Ultrasound that was done in the office yesterday shows consistently PSVRs of less than 2 on his follow-up ultrasound. Thank you very much.
Great case. Great case.